This is LiveWell Talk on General Cardiology. I'm Dr. Dustin Arnold, Chief Medical Officer at Unity Point Health St. Luke's Hospital. Joining me today is Dr. Ojas Bansal, cardiologist with St. Luke's Heart Care Clinic, to discuss general cardiology, the role of a cardiologist in a patient's care, when someone should seeing a cardiologist, and much more. Dr. Bansal, welcome to the podcast. Your first podcast.
This is my first podcast.
Yeah, welcome.
Thank you for having me. Yeah.
Well, Eldrazi did it. You can do it.
Yeah.
The bar's low. So there's no limit. Kettle Camp's been on here like 2 or 3 times.
Well, I'm
so
sure. Yeah.
then it's you're gonna do fine. But first of all, tell us a little bit about yourself. Where'd you train?
So
you've been here about 2 years, right?
No, I've been here 7 years.
Really?
Time flies.
Oh my
Yes.
gosh! It seems like you and Eldrazi came at the same time, right?
We came at the same time.
Oh, wow.
Yeah.
7 years?
7 years.
That blows my mind.
Yeah. So I did my internal medicine training at Creighton University in Omaha, and then right after that, I went into cardiology fellowship at the same place, and then I finished in 2016 with my general cardiology fellowship, and then I started right here.
Wow.
This is my first job right out of fellowship, and
It has been that long, hasn't it? Now that I think
yes.
about it, it's definitely before the pandemic.
Yeah.
And time does go fast. Well, you've quickly established yourself as a competent and caring cardiologist. And what we wanted to cover today is kind of general cardiology. How does that fit into a patient's care plan? I think cardiology definitely in the last 10 years, innovations just keep coming out. Advancements, electrophysiology, structural heart disease.
Yeah.
For a while there was just interventions and bypass
Yeah.
surgery, and it really has expanded. But there's still a significant role for a cardiologist.
Yes.
And kind of take us through that. How do you see a cardiologist's role in a patient's care plan?
So as you just said, the field has evolved, and that was the main thing that drew me into this field. Even from the start of my training, when I did finish medical school and went into internship, things had changed.
Oh, yeah.
So it used to be as just, meant heart attack, bypass surgeries, and intervention and stents. But then there's been so much research into this field, and every day, every month, we get something new, and the field has evolved. So heart is the most important organ which keeps the blood pumping through your body. And then as a cardiologist, when patients present to us, the main symptom can just be just not feeling good, or short of breath, or tired, or dizzy, or chest discomfort. That all stems from just the heart not being efficient. And then as a cardiologist, our role is to figure out what aspect of that function of the heart are we dealing with? Are we dealing with something to do with the like a reduced blood flow to the heart, or something to do with the reduced electrical activity, or hyperactive dysrhythmias, or slow heart function, or some kind of a valve problem? So sometimes you also deal with something where the heart muscle gets weak. So as a cardiologist, when a patient presents to us first, our job is to figure out what particular problem is the patient presenting with, and which of those particular organ systems within the heart, so to speak, is causing that. And then we have tools to have diagnosed that, by means of tests like echocardiograms, stress testing, Holter monitors, and such, and then come up with a plan to take care of the patient.
Yeah, I found it not, we talk about chest pain, and very few people present with chest pain to the outpatient clinic.
Correct.
The people having a heart attack, myocardial infarction, they show up with chest pain and they're sick.
Yeah.
And it's obvious.
Yeah.
You walk in and you're like, okay,
you
gotta go to the cath lab. This guy's got a heart attack. But I've always over the years found it impressive how it simply can be fatigue, and very few people present with chest pain. So if you do not keep your high index of suspicion up, or what neighborhood that the people live in with risk factors, you can miss heart disease pretty easily.
That is so true.
Particularly women.
Yeah, particularly women. In my practice, I see this very often. Some people, get referred by PCP just because of that high clinical, index of suspicion, or maybe just because they have certain risk factors or family history. And as you start, interviewing the patients and get into it, then there are subtle signs and symptoms that you start to pick up that points to maybe this is not just a simple fatigue or some people attribute it to aging. It's sometimes more than that, and that's why you have to have a very high index of suspicion for these patients.
Now, how much of your practice is primary prevention? I mean, how often do you discuss cholesterol management, high blood pressure, et cetera, with your patients?
I think every time.
Every time.
That is the key. That is the key. Primary prevention is the key. So we see prevention. I should say prevention is the key. Sometimes it's primary and sometimes it's secondary. Meaning sometimes we get patients referred to, as I said, to get evaluated, and you talk to them and about the risk factors, cholesterol management, blood pressure management, diabetes, lifestyle, exercise and stress management. That's a very key factor in heart disease prevention for sure.
It's not smoking.
Yes, 100%. Yeah, not smoking. Yeah. So those are the top 6-7 things that go into keeping, having a good, healthy, healthy life.
What about the aspirin? I think a lot of listeners have been prescribed aspirin, whether it's primary, prior to having an event, or secondary. What is the role of aspirin at this time?
Aspirin is has been a topic of debate. And there's a lot more research that's been gone into it, especially in the recent years. One thing is clear: people who've had an event, a heart attack or stroke, 100% benefit from being on aspirin. As far as in terms of primary prevention, people who have not had any cardiac event or stroke, the role of aspirin now is pretty limited. And we do not routinely prescribe aspirin for primary prevention use.
If somebody's already on it, do you just keep them on it?
No.
You'll take them off of it?
Yeah, we'll take them off. There's a very small subset of people who may benefit from it. But again, the aspirin, the reason behind, we need to know what the reason behind not routinely prescribing aspirin is because it's not a benign drug.
No. If we invented aspirin yesterday, it'd be about $11 a pill.
Yeah.
And it'd be prescription.
Yes.
And it would be,
because the drug comes with some potential side effects.
It's a powerful medication.
It is a very powerful med. So that's why a routine use of aspirin is not recommended anymore.
It makes sense.
Yeah.
It's interesting how the things change over time. You're saying that, and I was thinking back when I first started in practice, 1996. People came in with heart attacks, and you cooled them down. Then you did a nuclear stress test, and to see if there was a deficit. And if it was fixed, you didn't do anything. You just put them on medicine, and then the Denmark study and, getting people to cath lab sooner. And it reminds me, I had an internist who was my patient. He was in his late 90s at the time. And he was telling me, like, when he first started, people had heart attacks, you put them in bed for a month.
Yes.
Said, okay, go to bed for a month, go lay in bed for a month, and then, and that's just mind-boggling now. But that was the standard of care. So sometimes I wonder, will my grandkids go, can you believe my grandpa managed people's cholesterol for heart disease? You wonder, sometimes you're doing this stuff and you're like, okay, it's like 100 years from now, they'll say, oh, can you believe that they actually thought cholesterol is important?
Yeah.
Things change over time.
I think there will come a pill which you could take and it would sort of take care of dissolve cholesterol completely.
Yeah.
Take it. I think technology is evolving so much that if you're having a heart attack, I think your smartwatches or your devices could tell, or certain changes in your body and warn you about it. So I think it sounds futuristic, but I think all these things are coming. Yeah.
I can remember that when the pacers, defibrillators first came out and became routine, how they would ping cell phone towers if you had like a non-sustained arrhythmia.
Yeah.
You know, the patient get a call from the doctor the next day, say, "Hey, yeah, yesterday you had," and that blew my mind. I thought that, now it's the electrophysiology and all that's advanced way past that, of course. How often do you see end-stage heart failure like we used to? It seems like now with defibrillators and advancements in electrophysiology that it doesn't feel like I see as many patients with the EF of 10 or 15 anymore that with advancements. I mean, is that still a significant part of a cardiologist's practice?
It is still a good part of the cardiology practice, but you're right. It's not as big as it used to be.
Yeah.
But it's still
which is a good thing.
Yeah, which is a good thing. Yeah, and that's mainly because of advent of a few things, as you mentioned. One is newer medications for these patients for heart failure that have come up in the last in the last decade or 5 years. We have had new medications to take care of heart failure patients. Just to give you a few examples, like Entresto was one of them, and some other actually diabetes medications that are actually helpful and we know help improve heart function. So those have dramatically changed a big paradigm shift in taking care of heart failure. And then comes the second piece to it, which is more advanced and technology based, which involves certain special kinds of pacemakers like biventricular pacemakers and such that have really helped improve heart function. And then third thing is a lot of these patients used to have arrhythmias in conjunction that would cause more heart failure. And now we have, our electrophysiologists, that can take care of those successfully with both newer medications and ablations.
Yeah, procedures.
Like procedures to take care of that. That has, led to improvement in that field, and less patients have this end stage heart failure and cardiomyopathy now.
Do you think you see less in your practice, less valvular heart disease with less rheumatic? Because it used to be in my practice, people born before penicillin had rheumatic heart disease, right? And they lived long enough.
Correct.
Or Eskimos, native populations that didn't have opportunities to have amoxicillin when they were children, right?
Yeah.
Do you see less of that? I mean, it seems like with TAVR and...
So yes, we see less of those rheumatic type valve disease anymore. But in general, I feel the valve disease is more now compared to before.
Really?
Way more than before.
What's your theory on that?
My theory on that is
you can make up in something because I'm going to believe you.
My theory
I trust you.
is going back to we just discussed. Because of the the medications and the newer techniques, people are living longer, living healthier. The median survival age back 50 years was 63, 64.
Yeah, that's hard to believe, isn't it?
And now we are at 74, 75. So because people we live longer, we live healthier. The valves in general have some people, not every, have an inherent so to speak, a life. They start degenerating, disintegrating over time, and they attract some deposition of plaque and calcium just by wear and tear, everyday work. So the longer it works, I think there's a little more wear and tear each time. And now patients are presenting in their late 70s, 80s, or even 90s for that matter, with degeneration of valve, like the mitral valve causing leakiness, like mitral regurgitation, or aortic stenosis, narrowing of aortic valve. So we are taking care of more and more patients now with a basically degenerative type of valve disease compared to infection or rheumatic disease related heart disease, and that has led us into newer techniques and technology to take care of these.
Right. Yeah.
Because a lot of our patients now are elderly. And instead of putting them through a big major heart surgery, open heart surgery, now we have newer minimally invasive catheter-based techniques and procedures to take care of these valves.
Yeah, it seems like something new comes out.
Yeah.
You know,
every
I got to chase after Corona and kettle camp all
yeah,
the time because we've got
yes,
something new coming out all the
every
time.
6 months it's
Yeah,
evolving,
yeah.
and it is. So I feel old just how I look at the literature and the development in the web. I graduated, finished 7 years ago, and in that realm, this whole thing, the field has evolved so much, and we have specialists, Dr. Crony and Kettle Camp in our team, who have really honed that skill to take care of those complex structural heart disease, valve disease patients.
It is fascinating.
Yeah.
COVID-19, whether it's the infection itself or the vaccine associated with myocarditis, did you see some of those cases?
I did.
Did you?
I did.
Tell us about that.
I've seen, so the COVID-19. So let me first talk about the virus itself related myocarditis. I have seen some people present in the hospital when they're admitted, like a pretty profound fulminant myocarditis affecting, the heart muscle is, EF is low, gets down. And then also seen some more subtle forms of this, which doesn't quite affect the heart, the myocarditis, the muscle, but it does lead to some arrhythmic type of events, especially some, palpitations, heart racing, or things like that, which I think are more subtle forms of just the same problem. I've seen a lot of them recover, but it's taking a long time compared to some of the other viral myocarditis, which I saw would recover faster, usually within a month. These have taken, some of my patients, it's taken them longer to recover from these. As far as vaccines go, in my practice, I can just say I've seen one that had.
You could say it was related to the vaccine.
It was
younger.
One, and this is a person who's had, my history from a viral myocarditis before, even in the past. So I think so he had a recurrent episode after the vaccine.
Interesting.
Yeah, but it was mild, and he, it was short-lived and recovered pretty quick. But I think it was a younger patient who had sort of some kind of genetic predisposition to this, and did get a case of that.
And definitely you've seen an uptick in the number of cases of myocarditis in younger people, whether it's the vaccine or the virus, than prior to the pandemic.
Yes.
Just on the hospital service, you'd have one every winter, young person. Usually you had this persistent cough. They didn't show up in heart failure, just this persistent cough, multiple courses of antibiotics, and they find out they've had a Coxsackie myocarditis, and they usually get better. Some people, as you know, can get transplant, but you definitely seen an increase in that.
I have, even the number of ER patients that I've seen, or the hospital side, it was higher this year compared to what I've seen before on service.
It's interesting to relate. Some countries in Europe don't recommend vaccines for under the age of 50 because of that, and I certainly have changed my approach to that, and looked at it as we always did, say, or what are the risk factors here?
Yeah.
Is there a risk to benefit ratio, as you do that every day? High blood pressure. How much of your practice is just blood pressure management?
It's a good part of of my practice. Again, it comes with usually a lot of it is done by primary cares, routine blood pressure management. But when it comes to becoming resistant, where you need 2 or 3 different medications and such, then I do get referrals for them, mainly to see if there is any other underlying cause, secondary cause for it, and to see if there are some medication adjustments we can do. And then the other piece is, high blood pressure, is a big piece, big risk factor to heart disease. So patients who have heart disease that I see who have high blood pressures in conjunction, I do take care of that as well.
And how often, patient that you're following for blood pressure, how often would you see him every year?
It depends. Once we get them stabilized, enough on the medication, then it's every 6 months. But I strongly a lot of it is done now with home blood pressure monitoring. So that's why what I encourage all my patients to start learning home blood pressure. It's a very powerful, very good tool to do. So for high blood pressure, I have a lot of patients doing home blood pressure monitoring, and I have them send blood pressure readings, on a monthly basis. It's a good habit for everybody who has high blood pressure to check your blood pressure every day.
Yeah. Well, and I think people don't understand it's a dynamic measurement.
Yeah, it is. Yeah.
You can't just take one
and
reading
know that
in the
your
office.
Blood pressure is controlled.
That's either controlled or uncontrolled.
Uncontrolled. Yeah,
absolutely.
There's a new entity that is being, talked about in research. The evolution of masked hypertension. Your blood pressure is good in the office, but it's actually higher at home, 10 points higher. It's the opposite of what you hear, the white coat hypertension. And that is also being recognized as a new entity, and hence, the more monitoring at home for that to find that out.
I used to have a 15-10 rule. So people would say, oh, my blood pressure is always high when I come to the office. I'd say, well, my rule is systolic, let's subtract 15, and let's subtract 10 from the diastolic. And if they were still high at that time, we made adjustments.
Yeah, it works. So usually they're more relaxed at home, and so we got it. So, but the new blood pressure monitoring systems are pretty good now. So
I definitely think
we
yes,
get good data
compared to the
that,
original ones that came out. Yeah, they were very. Well, it's like a treadmill. I mean, the money in the treadmill is the motor. The computer stuff now is cheap. I mean, it's same with that, and it's quite advanced. So we've talked about let's keep the diabetes under control, no smoking, no cholesterol, active lifestyle, keep the blood pressure controlled. Did we miss anything for heart disease?
Diet. Yeah. Diet involves, lots of fruits and vegetables, 6 to 7 servings of fresh fruits and vegetables.
One thing we didn't talk about, and I think we should because I think it's important for listeners to understand the correlation, is obstructive sleep apnea.
Oh, yes.
And heart disease.
Yes. That is another risk factors for heart disease that is I'm seeing more and more of.
And it's not just, I mean, I've got a 19-inch neck, 19.5, something like that. But there's skinny people that have obstructive sleep apnea. I think you have to consider it.
So, it's for everybody.
Yeah.
So besides, some of the lifestyle risk factors, weight or and such, I think there's something more to it.
Yeah.
That we still completely don't know. As you said, why do some of the skinny people, who do not have the neck circumference or whatnot, obesity have it, and then also comes central sleep apnea.
Right.
Where it's not because of obstruction to the airway, but just
they stop breathing.
Just stop breathing. Just become apneic. So that is one of those non-traditional, non-conventional risk factors. These that we definitely have to look into, because that is associated with almost every aspect of heart disease now.
It is. It's
heart attack, blockages, arrhythmias for sure is a big one, especially atrial fibrillation. And valve diseases now are also being caused by sleep apnea, especially the right-sided valve disease, like heart failures. So yes, almost every aspect of cardiac care now that does play a role, and that has to be screened, have a very high index of suspicion, and treated appropriately.
Right.
To take
and it makes sense. I mean, you hold your breath for 30 seconds.
You're not getting oxygen
for 8 hours. You're hypoxic, and
that does take a toll on your efficiency of your heart function. 100%.
Yeah, I'm glad we didn't skip over that, because why did you chose cardiology? Because of the innovations. I mean, what else attracted you to cardiology?
It's just there's so much in this field. both from how the patient presents. A lot lies in your first interaction. You learn so much about the patient, and that kind of gives you a hint as to what possibly is going on. And then in this field, there's so much, or there are so many tools like diagnostic, tools available to help find out exactly, very precisely. It's a pretty precise field as to what is going on.
Yeah.
The rhythm, and then once you diagnose, then there are so many tools again as to take it to the next step to take care of it. So I just found it very fascinating to just have so much available to help take care of the patients, and that really made an impact. It helps improve their quality of life and longevity, and
Absolutely.
it can be in different settings, every possible office based, or is you can take care of then emergency settings, or hospital, and both you take care of patients in the hospital, and then you get to see them doing so well in the clinic. So I think the whole the length and breadth of this field just got me so attracted, and when
your heart
to do it.
Your heart starts beating prior to being born, and
Yes,
it goes until you die, right? I mean, never stops.
Never stops.
Well, thanks for joining me. You did
Thank
a great
you.
job.
Thank you.
And your enthusiasm for cardiology and your compassion towards patients is measurable. You're doing a great job.
Thank you so much.
I'm glad you're here. And I can't believe it's been 7 years.
7 years.
We kept you.
Yeah.
Yeah, I think we made the right decision. Dr. Bansal, thank you for joining me and informing our listeners about general cardiology. Once again, this is Dr. Ojas Bansal, cardiologist with St. Luke's Heart Care Clinic. To learn more, visit unitypoint.org/heartcare. Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe. And if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.